Thanks for joining us. We'll be discussing radiation therapy's role in treating oligometastatic cancer. These are our disclosures. All right, so here's the agenda for this evening. We'll cover a discussion of radiation therapy, just briefly to catch everybody up to speed. We'll talk a little bit about the development of metastatic cancer and so-called oligometastatic cancer, principles of treatment of oligometastatic cancer, radiation therapy in particular for oligometastasis. Dr. Feng and I both treat GU cancers, and so we'll be discussing prostate cancer as sort of a case study to discuss key principles in the treatment of oligometastatic cancer, and then studies that are on the horizon and sort of future steps going forward for the field. So what is radiation therapy? So about half of cancer patients will receive radiotherapy during the course of their treatments. It's perhaps a little bit, I guess, less commonly known than some of the other modalities that are used in treating cancer, such as surgery or chemotherapy or other systemic therapies. But it plays a major role in the curative treatment for a number of different cancers. And frequently, depending on the type of cancer, can be used in conjunction with other approaches, such as surgery or chemotherapy. And so the process of radiation involves sort of a series of steps for external beam radiation, which is the most common form of radiation. But we, on a routine basis, when we treat patients, have patients come in to do a CT scan that is used to basically scan a patient and facilitate the careful planning of a radiation treatment plan. And so essentially through this radiation through the CT scan and then a number of computational steps, we develop a plan that allows us to deliver radiation essentially where we want it and prevent it from going to areas that we don't want it to go. And so this is just a quick kind of snapshot of a radiation plan for prostate cancer. And the idea is to get radiation to the prostate and minimize radiation to other nearby important structures, things such as the bladder, which sits on top of the prostate, and then the rectum, which sits immediately behind. And these principles are used in general for our radiation planning processes and some of the precise forms of radiation that we'll be discussing this evening. And then once that plan is put in place and quality assured, patients come in on a daily basis for a number of treatments, which can range from one single treatment and for longer courses up to 9 weeks, where they come in and receive their radiation. They basically lie on something that's similar to an X-ray table. And then there's a radiation machine that delivers the radiation plan that was developed on the computer prior to that. And I always find this a really neat image, but the advances in technology, which we'll touch on a little bit as we discuss oligometastatic cancer, have enabled us to create really precise radiation plans. And some of these are fairly complex, which involve sort of the changing shape of radiation beams as a radiation beam is being delivered. And that really allows us to sculpt radiation around very specific targets. And in the treatment of oligometastatic cancer, this can be particularly important depending on the target. So a little bit about oligometastatic cancer and more broadly metastatic cancer itself. So metastatic cancer is when cancer has left the primary site and gone somewhere distantly to, for instance, a different site. So a couple of images here, but metastatic cancer going to the lung or to the bone. And really, there are characteristics in cancer that allow it to sort of go to distant locations and sort of settle in and become and form metastases. And so this biologic process is important in development. And so, for example, in situations where cancer cells migrate to the lung, these cancer cells typically have basically the ability to get through the blood vessel linings and then get into sort of the lung tissue. Whereas in metastatic disease that is going to the bone, it has other processes to allow it to basically sort of form into areas or I guess, survive in areas of bone. And so these sort of different biologic differences can drive different sort of tendencies for cancer to go to other distant sites. Now, oligometastatic cancer is a concept that has been appreciated more, particularly more recently. And so oligometastatic cancer was, I think, most popularly discussed by these two physicians at the University of Chicago, Sam Hellman and Ralph Wexelbaum, and was described as an intermediate state of cancer that was essentially between localized disease and widespread metastasis. So the concept was that metastatic cancer does not exist in sort of absolute states where a patient has metastatic disease or not, but rather that there's a spectrum of metastatic disease. And in situations where cancer has migrated to fewer sites, these patients may have more indolent disease or potentially have the opportunity for curative strategies. And that was something that they highlighted in an editorial written back in the mid-90s. And so the idea was that some of these patients would be able to undergo more aggressive local forms of treatment to try to eliminate these limited sites of metastatic cancer. Now, metastatic cancer has largely been based on imaging historically. And so these are just kind of two examples demonstrating the differences between widely metastatic cancer and more limited metastatic cancer. But imaging has changed quite a bit over the years, and you can imagine that from 1995 to the present, our ability to detect cancer in different locations has really improved and really changed. And so it's been a little bit of a moving target to really define oligometastatic cancer for each specific cancer type. With all of these changes, with the introduction of PET scans and other more advanced imaging modalities, there have been also changes in our ability to identify patients who are appropriate for more aggressive treatments.
So I'm going to take over just briefly here. And the point that, Dr. Hahn and I want to make is that the imaging and detection are getting better. And this has revolutionized the detection of metastatic disease and has led to really advances in this space of oligometastatic or limited metastatic disease. Really, in the context of, let's say, prostate cancer, the utilization of a newer form of imaging called PET imaging with special kind of what we call tracers that are picked up by the PET scan really has changed and has increased the oligometastatic space. And so there's a form of imaging called PSMA, or prostate specific membrane antigen PET. And this is a PET scan that really picks up a kind of a protein that's really only found in prostate-related tissues. And this was actually first popularized abroad, actually in Europe and Australia. And so this is actually plots showing the utilization of PSMA PET in a large center, the Peter MacCallum Cancer Center in Melbourne, starting in 2010 to 2014. And you can see a tremendous increase in yellow in the utilization of PSMA PET. And in the United States, UCSF probably was one of the first centers to really popularize the use of PSMA PET. You can see that from 2016 to 2017, our utilization of PSMA PET really increased. And I want to point out that recently our radiology team, led by Dr. Tom Hope, actually submitted an application to the FDA for approval of PSMA PET for use in patients with aggressive prostate cancers. And so because of that, I think that this technology will now be generalizable to the rest of the United States. And it's not only this PSMA PET scan that's picked up in terms of utilization. There's another type of scan called an Axman PET scan that's slightly less specific for prostate cancer, but still relatively quite good. And that has become FDA approved as well, and now is reimbursed by insurance companies as well. And And so one thing we do know is that using these advanced PET imaging approaches actually allows us to detect metastatic disease where previously we couldn't detect metastatic disease. And so in prostate cancer, there's a blood biomarker called PSA, a prostate-specific antigen that's obtained in prostate cancer patients to track whether the disease is progressing or not progressing. And previously, when patients had low PSAs, we knew that the original or our original imaging approaches like CT scans and bone scans really were not going to pick up prostate cancer. But now at really low PSAs, even down to 0.2, which is a really low level, we can start seeing actually prostate cancer kind of outside of the pelvis, which is consistent with metastatic disease, or even within the pelvis as well. And so here's data from these two different PET imaging approaches, Axeman PET on the left and PSMA PET on the right. And really, I think that the point is twofold. Number one, as the burden of prostate cancer increases, meaning increasing PSA levels, certainly you can detect more disease, but that even at very low PSA levels, now we can see prostate cancer in 40% of patients with a PSA of 0.2 or less. And there's just, in the past, that chance would have been about 5%. And I want to point out the study on the right is actually led by our course moderator, Dr. Lauren Beretta. The other thing is that not all imaging approaches are the same. And so this was a randomized study looking at these two imaging approaches. I showed you PSMA PET and fluciclovine PET. And what this is meant to show is that the blue bars, which is the detection of cancer by PSMA PET, is better than the detection of cancer by Axeman or fluciclovine PET. And so, I think we're in the infancy of the field of molecular imaging, but as data like this becomes more widespread, what we'll be able to do is not only develop more sensitive approaches for detecting prostate and other cancers, but also optimize between different approaches as well. And then, what I also want to point out is that, at UCSF, this is our experience with patients specifically with PSA recurrences after surgery. And I want to point out that even at these low PSAs, not only did 38% of patients have a spot or a lesion of cancer that's outside of the pelvis consistent with metastatic disease, but that 30% of these patients actually had a spot outside of what we would usually craft a standard radiation field around. And so this imaging approach not only detects disease, but detects disease that probably will inform how we give radiation and hopefully improve the cure of patients. So at this point in time, I'm going to turn things back over to Dr. Hong.
Great, thanks, Dr. Fei. So the next thing we'll discuss is, are there different types of oligometastasis? So we sort of distinguished between oligometastasis, so-called limited metastatic cancer in comparison to widely metastatic cancer. But there are a number of features that we've sort of started to incorporate more in our thinking and our rationale for what constitutes different types of oligometastatic cancer. And these have largely been defined by the extent of cancer, so the similarly to widely metastatic versus oligometastatic, but how many lesions there are or how many areas of cancer there are. The time course, so when these areas of cancer that are spread are detected, whether it's at the time of initial diagnosis or at another period of time that's later on, as well as treatments. And so to kind of show a few of the guidelines that have been sort of proposed as far as categorizing these types of oligometastatic cancer, there's what we call synchronous oligometastatic disease. And that basically represents an area where you have the primary cancer, but then you have these other areas that have spread to the other lung, for instance, in this image, all at the same time as the original cancer. There's also what's called metachronous oligorecurrence. And in this example, you have an initial cancer that's been treated, and then some period of time down the road, other areas of cancer develop, but are still limited in number. And so those still constitute sort of a subgroup of oligometastatic cancer. But that time component can tell you a little bit about the biology of the cancer itself. There's also sort of two elements as far as oligo recurrence. One is repeat oligo recurrence, where there's initially some cancer that is treated and then new areas come up later on. But there's also an induced oligo recurrence where initially there's potentially even more widely metastatic cancer that's at the very beginning. But then after undergoing treatment, the cancer becomes more limited in number. And that's been classified as induced oligorecurrence, where there's areas that have been treated, they've shrunk down, and then very few or limited areas where the cancer is active during treatment or after treatment. So we'll discuss a little bit about the concepts of how we, approach the treatment of metastatic disease. And Dr. Fang will cover this a bit when we use prostate cancer as a case example. But there are certain principles that we sort of think of. First of all, that both the primary area of cancer and existing metastases, so all areas of cancer that we know of, are capable of seeding new areas of disease. And so the principal mode of spread is typically metastasis to metastasis. And we'll discuss the patterns of spread in a little bit more detail as well. But the fundamental premise that comes from this, and I think it probably makes sense, which is that in order to cure oligometastatic cancer, one likely needs to treat both the primary itself, where the cancer originally came from, as well as any areas of metastatic cancer. And so the process of learning more about oligometastatic cancer has kind of taken place over the course of decades. This is an older study from the 80s that demonstrates that that we knew that the amount of cancer at the very beginning, and so this is a study in breast cancer, the amount of cancer at the beginning, or extent of disease, in this case, they sort of designated that category as patients with 5 or fewer areas of cancer. Those patients tended to have a more favorable outcome. And so here, the relative risk was 0.8 or less than 1, which suggests that they had a better outcome than the reference group. And those are patients who were just treated with chemotherapy without directed courses of treatment to try to eliminate areas of metastatic disease. We've also learned a few other kind of key elements that are important in the spread of oligometastatic cancer. There was a series that was from the University of Rochester that showed that patients who were treated for oligometastatic cancer typically had spread in the same organ. And so, for instance, patients that were treated for areas of cancer in the liver, for instance, were more likely, if they did have recurrent cancer, we're more likely to have it in the same area in the liver. The other important element is that patients who have started with limited metastatic cancer typically progress in fewer numbers of areas. And so a study from the University of Chicago where patients were treated with oligometastatic cancer showed that 72% of patients who did progressed in few areas. So rather than progressing widely, these patients' cancer's biology appeared to sort of spread a little bit slower. And this same group corroborated some of these findings by looking at microRNA expression. And basically they found that there were differential patterns of expression which were correlated with long-term outcomes for patients that were treated with focused radiation. Which actually takes us into our next section, which is principles of treatment for oligometastatic cancer. So how do we treat metastases? There are a number of approaches that we kind of highlighted earlier when we were talking about the treatment of cancer more broadly. But systemic therapy is the cornerstone of treating cancer that's spread outside of its primary site. And that's important because it enables us to treat the entire body and treat cancer that has spread to more than one site. But there are also focused, more aggressive approaches at trying to treat areas of limited cancer that have spread. Historically, surgery's been the thing that's been around the longest. And then we'll talk about radiation in a couple of forms, and then ablative focal techniques as well. And so all three of these have been used in the past and continue to have some role going forward as well. So surgical resection or metastasectomy, the removal of metastases, has been used for quite some time. And this is a historical series that basically shows kind of a nice example where patients who underwent surgical resection of their lung metastases or cancer that has spread to the lungs, we're more likely to have more favorable outcomes. And I think this is the first survival curve that we have in our slideshow, so I'll talk you through this. But basically, on the y-axis here, this is the proportion of patients who are surviving over time, which is the x-axis. And so these are the patients over here on the top that did undergo surgery and patients who did not undergo surgery. This was an observational study, so it has some caveats of not being randomized, but it was these early surgical series that suggested that patients may have improved outcomes while trying to treat localized areas of cancer definitively. And most of these early series focused on specific sites where cancer had spread before, so in the lung or in the liver or other specific sites like that. Radiofrequency ablation is a way to use radiofrequency waves via basically a probe to kill cancer. And so this is a procedure that's done by our interventional radiology colleagues, frequently used for liver metastases. And the study that I wanted to highlight was one that was specifically done in colorectal cancer, where they treated limited sites of a liver metastases with or without or they either did or did not receive this radiofrequency ablation to limited liver metastases, finding that patients actually had a longer course of survival if they did undergo this focused treatment to the liver metastases. So Dr. Fang and I, of course, do radiation treatments, and I think that's the embedded in the title of our talk tonight. And so really an important advancement over the past couple of decades has been the advent of what we call stereotactic body radiation therapy, or SBRT for short. It's used for a number of primary cancers, and I kind of highlighted a couple here, lung and pancreas. We also use it frequently to treat oligometastases. And it basically involves the similar principles to what we discussed in our design of radiation plan, but the idea is to give precise image-guided treatments with high-dose radiation in few treatments, usually defined as 5 or fewer treatments. And this is an example of a treatment plan delivered to a lesion in the lung. And that was actually specifically a treatment for an oligometastatic tumor that had developed in the lung. So in investigating radiation, there were a number of early studies that sort of piloted some of the data to show that there were favorable outcomes. So these weren't randomized studies, but they were exploratory studies to see what kinds of outcomes occurred when patients with oligometastatic cancer were treated with aggressive radiation with focused SBRT. And our group had previously taken a look at some of these cancers when I was a resident, where we pulled the data from these early studies and tried to see if there were certain characteristics that separated out patients who had better outcomes than others. And so this was, we basically developed an analysis that creates a decision tree that breaks down different characteristics and how they interact with each other. Essentially, in this study, we found that there were different classes of patients that were on these studies that had differential outcomes. And so patients with limited metastatic disease that were treated and had originally had primary breast, kidney, or prostate cancers had the most favorable outcomes among this group. And this is a theme that's seen in the clinical trial designs and sort of the areas that we've really focused the application of these treatments to. We also found that for patients with other types of diseases or other types of cancers, that the time to the development of metastatic cancer is also important within that class. And that sort of harkens back to the so-called metachronous oligometastatic cancer, which has some different biological traits in comparison to more synchronous metastatic cancer. And then patients who have more rapidly occurring metastatic cancer, who have fewer metastatic sites, tend to also have more favorable prognoses. And then among the patients who have, faster developing metastatic cancer, but have a little bit more number of metastases between 3 and 5, patients who were younger typically had better outcomes. And so these were some fundamental principles that separated some of the classes and gives a little bit of context for thinking about some of the studies that have come up since then. So a really important study that was published recently is called the Saber Comet study. Saber is actually another term for SBRT. It stands for stereotactic ablative radiotherapy. And so there's the Saber camp and the SBRT camp for which acronym folks should be using to describe the treatment. But Saber Comet was an important phase 2 randomized trial where they took patients with a number of different types of cancer, but all patients had to have oligometastatic cancer, which they defined in this study as 5 metastatic lesions or fewer. And patients were randomized to either palliative radiotherapy to symptomatic sites or standard systemic therapy in comparison to more aggressive radiation approaches with SBRT, where these lesions were treated specifically with the goal of eliminating those spots. And so this study actually randomized patients in a 1-to-2 allocation where more of the patients received the aggressive radiation approach. But the finding of this study was that the patients who received more aggressive radiation or SBRT, those patients actually lived longer. So this red line right here represents patients who were treated with SBRT or Saber in comparison to patients who received the standard of care, either systemic therapy with or without less aggressive radiation approaches. The study also found that patients who underwent SBRT had a longer period of what's called progression-free survival. And so that, in addition to considering how long patients live, also factors in how long they live without new cancer developing. And so that was another finding from the study. Now, Saber Comet was designed as a little bit more of a limited study, and so it's not a gold standard phase 3 study, which is larger, as more of an exploratory randomized study. And one of the main criticisms of Saber Comet is that there was some imbalance between the two groups that were randomized in the study. And if you think back to our prognostic indicators, one of the sort of more clear ones is the imbalance between the types of primary cancers that were randomized in each one of the arms. And so, one of the caveats with looking at the Saber Comet study is that there were more patients with more favorable characteristics, more patients with prostate cancer and more patients with breast cancer, which may have been partially responsible for some of the findings. But it's an important study nevertheless, and we'll talk about some of the next steps that this study has driven. The other finding that I think was maybe a little bit surprising for us in general was that there were more adverse events associated with the use of SBRT in this treatment. And actually, there were 3 patients that had a death that was associated with their radiation. That wasn't significant in the study, but 3 that were noted in the radiation group, which I think was a little bit surprising for folks who were interpreting the results. But overall, in the long-term follow-up, they found that there was no difference in quality of life across the 2 true treatment groups. And this is from their long-term follow-up of their study across different domains in the Saber Comet study. So an important study that looked at treating different types of oligometastatic cancer aggressively. And I will pass it to Dr. Feng to discuss prostate cancer in more detail.
Absolutely. So one point that we're going to discuss today really is prostate cancer. And the reason why we're focusing on prostate cancer is, in addition to the fact that Dr. Han and I both treat prostate cancer, it's also a disease space in which radiation for oligometastatic disease has been more explored than in other cancer sites. So when we think about oligometastatic disease management, as Dr. Han alluded to, there are different ways to think about using both radiation and drug therapy to treat cancer in general that has spread to a limited number of metastatic sites. And in the context of prostate cancer, the way we think about it is treatment to the prostate itself, and that's prostate-directed therapy here. And then we think about metastasis-directed therapy, which, as Dr. Han just reviewed, includes things like radiation to the metastatic sites. And then we think about how to improve drug therapy for these patients, which I've termed systemic consolidative therapy in this particular setting. And so I'm going to first talk about treatment directed to the prostate in patients with limited metastatic disease. And in that context, there's actually a randomized phase 3 trial in this space of radiation versus no radiation to the primary tumor, meaning the prostate itself, in men with newly diagnosed metastatic prostate cancer. This is a study that was recently reported out that included over 2,000 patients, 40% of which had what we term a low metastatic burden, consistent with oligometastatic disease. And so here again are some of these Kaplan-Meier curves that Dr. Hong alluded to. And really, I think what I want to boil this down to is that in this particular study, you could break down patients by whether they had low metastatic burden, shown on the 2 Kaplan-Meier curves on the left, versus high metastatic burden, shown on the 2 Kaplan-Meier curves to the right. And on the top row, you can see the curves for overall survival, meaning who was alive and who wasn't. And on the bottom row, you can see failure-free survival, which is defined as who had recurrence or did not have recurrence, and also in addition, who was alive and who wasn't. And what I want to point out to you is in patients who have high metastatic burden on the right, there really is no benefit to radiation to the prostate in patients with limited metastatic disease, meaning that the patients who got the radiation shown on the blue curves did no better than the patients who did not get the radiation shown in the red. However, on the left, in patients with low metastatic burden, you can now see a nice separation of these curves, showing a benefit to radiation over no radiation to the prostate. And some of you might say, well, listen, those curves don't look too different, but these are what we call overall survival differences. And in the context of treatment for cancer, if you get a 10 to 15% difference in overall survival a few years down the road. That's actually relatively big by our standards. And so really, I think this is a meaningful study that shows that, in patients with limited metastatic disease with prostate cancer, that we should radiate the prostate itself. And this also has implications for other disease sites. So, can these findings potentially hold up outside of prostate cancer, with, let's say, breast cancer or other cancers that are known to have limited metastatic spread? And the answer is, I think it's to be determined, but certainly an exciting area of future research. Going back to these three pillars of treatment for oligometastatic disease, I want to now move on to the concept of metastasis-directed therapy. And Dr. Hong really reviewed the largest study in this space when he talked about the Saber Comet trial. Again, that trial was for patients with a variety of different kinds of cancer. I'm going to point to two randomized studies of radiation versus no radiation to the metastatic sites, specifically in the context of prostate cancer. And these two studies are the STOMP trial and the Oriole study. So with the STOMP study, this was a study of surveillance versus metastasis-directed therapy for patients with oligometastatic prostate cancer run out of Belgium. And really, in this study, the study took patients who had a PSA or prostate cancer recurrences following either surgery or radiation for their prostate cancer. And then they used a new type of PET imaging called colding PET to detect metastasis. Those patients who just had a limited number of metastatic spots, again, consistent with oligometastatic disease, were randomized, in this case, to either radiation or surgery to remove all sites of metastatic disease or just following these patients. And the primary endpoint was actually how long they could stay off of drug therapy, which in the context of prostate cancer is called androgen deprivation therapy, or ADT. And in this study, what you can see is that patients who received radiation or surgery to the metastasis, which are shown in blue, actually did better. And so on the left is what we call a waterfall plot. And this waterfall plot basically demonstrates in this case, the maximal PSA response. And so PSA, again, is this blood marker that shows the amount of prostate cancer that a patient has. And what you can see is that the patients who received metastasis-directed therapy are shown in blue, and there's a lot of them on the right side where the PSAs really went down versus on the patients who were followed with surveillance shown in red, where most of these patients had their PSAs increase. And on the right, you can see again these Kaplan-Meier curves where, again, patients shown with the blue curve did better in the sense that the curve is higher and to the right, and meaning that radiation actually decreased the number of recurrences and the time to recurrence as well. And the Oriole study is the other study in this space. And again, this study was a little bit different in the sense that it used conventional imaging, CT or bone scan, to define these oligometastatic patients, but it showed a very similar finding, which is that if you give radiation to the metastasis, it's much better than not giving radiation to the metastasis in terms of progression-free survival as well. And what was particularly interesting about the Oriole study is that in addition to conventional CT scan and bone scan, which was used to define eligibility for the study, many of these patients also received these new PSMA PET imaging studies. And what was shown actually is that those patients who happen to have radiation to all sites of disease shown on the PSMA PET scan actually did much better than those patients where only a few of the sites and not all the sites of metastasis in the patient were radiated. And remember, they had used the conventional CT scan or bone scan to define the metastasis. And that's why if you're using that to direct your radiation, you might miss one or two sites of metastasis as well. And this is the Kaplan-Meier curve showing that, again, patients who got all sites of metastasis radiated, shown in blue, did much better than the patients where only a few of the sites were radiated and some were left untreated as well. And so I think what this shows is that, and this is not that surprising, but if you can get rid of all the cancer or target all the cancer that you can see with these new imaging approaches with radiation, patients do better. And so at this point in time, I want to pause and talk about a tale of two patients. these are both patients that I ended up eventually treating here at UCSF. And they actually have similar presentations, but different outcomes. And so patient one is a patient with prostate cancer who had prostatectomy, meaning surgery for removal of his prostate. In 2007, he had some aggressive disease, and the Gleason score indicates the aggressiveness of the disease. He then had the cancer come back as evidenced by increase in PSA, and he was treated with salvage radiation and 4 months of androgen deprivation therapy, which is a drug therapy used for prostate cancer. When he saw me, by that point in time, he had presented with oligometastatic disease to the left pubic ramus, which is shown in red here. So it's a bone in the pelvis with a slowly rising PSA to 1.3. He had no other detectable sites of disease. And so he had previously received all his treatment at an outside hospital up until 2017 when he presented to me. Now, what's interesting was I went back to his old records from the other hospital, and I got the old CT scan from 2013. And what you can see here is that in 2013, he actually had this little spot of disease, again, in this left pubic ramus that we can now see in 2017. Radiation therapy was given to him at the outside hospital in 2013, but they didn't see this particular spot, and so they didn't treat the spot. And what I want to point out is that this particular patient had a single site of metastasis that was untreated, and despite no treatment, actually this spot didn't progress for 4 years. It didn't spread to any other sites in the body as far as we can tell. He had no emergence of any additional metastasis during this period. And so what happened was that I ended up radiating him, and this was in 2017. Now it's 2020. He still has no evidence of disease. So this is an example of a patient who, for whatever reason, his cancer spread to the bone. It spread to the bone at one site. It didn't progress over 4 years. And then when I treated him, I was able to functionally cure him as far as we can tell with radiation. Now, I want to point to another patient who actually had a very similar presentation in terms of imaging studies. He was also post radical prostatectomy, or means he had gotten his prostate cancer treated with surgery. His cancer had come back. He was also treated with salvage radiation therapy and short-term androgen deprivation therapy. So very similar treatment, and in 2017, you could see that he had, again, a spot of cancer also on his pubic ramus. So I radiated this spot, and the good news is that this particular spot went away, but multiple other spots in the same region appeared right after I radiated this first spot. And so here we have two patients with relatively similar imaging findings, very similar treatments. One is, as far as we can tell, cured. The other one, really had significant progression of disease. Again, primarily because the second patient probably had a few other spots of metastasis that we just couldn't see. And right after we treated the first one, the other one started growing. And so I think the point to make is that not all oligometastatic disease is the same. And so patient one, and we always say is, when we see disease, is it the tip of the iceberg, or is the disease that we see all there is? And so in patient one, the disease we saw was all there was. When we cured that or got rid of that with radiation, he had no other disease. The second patient, what we saw was just the tip of the iceberg, and we may have chopped off the top of the iceberg, but the problem is the bottom of the iceberg then surfaced. And so for patient one, I would say that radiation or intensification of local therapy like radiation to the primary and the sites of metastatic disease is the right way to treat this patient, and potentially can provide long-term disease control or even cure. But for the second patient, I would say that this patient, is somebody where radiation probably didn't help this patient because he had so many other sites of disease we couldn't detect. And this patient would have benefited for intensification of systemic therapy or drug-based therapy that could treat all the areas of cancer in the body, but potentially not in a curative manner, but at least could keep that at bay for quite some time. So I've talked about two of these pillars of management for oligometastatic disease. And now at this point in time, I want to move on to the third premise, which was systemic consolidative therapy, meaning drug-based therapy. And I just want to be brief about this, but there is a number of ongoing trials for patients with high-risk localized prostate cancer, where these patients are being randomized to, on clinical trials, are being treated with more intensification of drug-based therapies, either targeted against the androgen receptor, which is a driver of aggressive prostate cancer, or with chemotherapy. And what I would predict is that the subset of patients, on these studies, who actually have metastatic disease that can't be seen with conventional imaging, are the ones who are most likely to benefit from the intensification of drug therapy. And so at this point in time, I'm going to pass the baton back over to Dr. Hong.
All right, well, we'll wrap up with discussing studies that are on the horizon, that are coming through the pipeline. The first of these is actually a study that's already resulted, but I wanted to include it because it does cover an area where there's been a lot of interest, which is the potential relationship or synergistic effects of immunotherapy with SBRT and radiation. And so this was the Pembrort Trial, which basically was done as a multi-center study from the Netherlands, and a study in patients with oligometastatic non-small cell lung cancer. And pembrolizumab, which is the Pembro part of Pembrort, is a drug that's also known as Keytruda. This study basically investigated the response rates of cancer with pembrolizumab, with or without the use of SBRT. They found on this study that there was an improvement in overall response rates, but it did not end up meeting their pre-specified endpoint. But you can see that at least sort of visually, there was suggestion that the experimental arm may have some superiority over the control arm with the addition of radiation. One of the important features of this study, though, was that the SBRT benefit was particularly noted or driven in patients that did not have PD-L1 expression or programmed death ligand expression. And so the immunotherapy works by basically taking off some of the brakes on the immune system, which protect that stopped the body from it mounting an immune response against itself. And so some of these important characteristics can sort of define how well immunotherapy or checkpoint inhibitors work. So there are certain circumstances where radiation was a little bit more helpful in this study, particularly in the context where the pembrolizumab by itself didn't have as great of an effect on its own. An important study that's on the horizon and actually currently in sort of a pause phase right now is NRGB2. NRG is a large oncology clinical trials organization. So this is a national trial enrolling patients with locally controlled metastatic breast cancer with oligometastatic cancer. And it's actually accrued through the phase 2 component, which is the first part of the study, which is looking at whether or not the addition of the use of SBRT improves progression-free survival. So the study is currently pending maturation of some of the results of that component of the study. Pending those results, it'll proceed to a phase 3 component where the primary endpoint is to see if the addition of SBRT improves survival with a primary endpoint at 5 years. And then the Saber Comet study has also a derivative study, which is Saber Comet 3. This is a phase 3 study, which is designed to build off of the results of the earlier Saber Comet study with a larger population of patients. They've actually created a couple of studies that are based on how many sites of metastatic cancer patients have. And so they have multiple Saber Comet studies. But Saber Comet 3 is oriented towards patients who have 1 to 3, so really limited areas of metastatic cancer. And similarly to the original Saber Comet study, it's still a randomization between standard treatment versus standard treatment with the addition of SBRT to all sites of oligometastatic cancer. And then the core study, which stands for the conventional versus radioablation for extracranial oligometastases. This is a study that similarly to the Saber Comet study is using multiple types of cancers, or investigating multiple types of cancers with the use of SBRT. It's also a phase 2, phase 3 study. And the phase 2 component is really to assess feasibility and the ability to do SBRT and look at the potential improvement in progression-free survival. When it advances to the phase 3 component, it will actually have specific, I guess, core sub-studies that are focused on specific disease sites, prostate, lung, and breast cancer. And in that study, in those studies, we'll be investigating the impact of the use of SBRT on overall survival. So there are a number of, I think, other questions that we still have on the horizon, even beyond, looking at sort of these larger clinical trials. I think Dr. Feng really, gave a good example of, that there's still a lot of work to be done to really characterize who benefits from treatment. I think we're finding some of the broader strokes in the definition of the populations that are being studied on clinical trials, but I think there's still a lot of work there to be done to try to make sure that we give the most appropriate treatment to each patient. There are also questions with regards to when treatment should be given. There are a number of studies which we didn't touch on this evening, but the use of SBRT or focal radiation can be used at different points depending on the type of oligometastatic cancer patients have. And in some of those situations, maybe treatment that's given after using systemic agents like chemotherapy as a way to eliminate sort of residual areas of disease. And then I think Pembrort and some of the other studies that Dr. Feng touched on sort of beg questions to ask, how do we optimize the use of radiation with all of these new types of agents, that are being more commonly used in the treatment of patients across different types of cancers. There's a lot of enthusiasm around the use of immunotherapy, different targeted therapies in prostate cancer, augmenting the use of hormone therapy, and how does radiation fit in with all of these different agents, and how does it interact with these agents to improve outcomes? So I think with that, a couple of acknowledges, and we'll wrap things up and take questions.
Thank you so much, both of you. That was a fantastic talk. I learned a lot, and I'm sure our audience did as well. Dr. Fisher, thank you for your note. I guess this is a two-parter. Maybe Felix, you can address the first part. What is the best modality for determining extent and location of metastases? Is there a specific imaging test?
Yeah, I'll take the first part of the question, and then you can take the second part, Dr. Hong. And so the first part was, what's the best modality for determining the extent and location of metastasis? And I would say it actually depends on the type of cancer you're looking at. And so for something like prostate cancer, I think these PET scans directed where the tracer is focused on a prostate-specific target is by far and away the best imaging approach. I think that for cancers where there aren't specific tracers, I would say that certainly a whole body MRI is going to be a better, is probably going to be more sensitive than a CT scan. But at the same time, it kind of depends. Like, for example, it also depends on what part of the body you're looking at, in the sense that, for example, whole body MRI doesn't do as well in the lungs where there's more motion from respiration. So in that area, kind of high-res CT scans would be, better. Dr. Hong, any further comments on top of that?
No, I think you nailed the key point, which is that it's dependent on the specific type of cancer and dependent on the site that we're trying to evaluate. So
the second part of Dr. Fisher's question was, is the radiation treatment in the brain different from the other areas in the oligometastatic setting?
Yeah. So radiation treatments in the brain actually are, I'd argue, were sort of the inspiration for SBRT to other sites. So stereotactic radiation was initially developed for the treatment of brain metastases. And actually the term stereotactic is probably most appropriately used in those contexts because the use of radiosurgery or stereotactic radiosurgery was applied using a grid, which sort of is where the term comes from, and so the principles are sort of that's the origin of the use of these high dose radiation treatments. Part of the reason that the brain was sort of the first site this was used in is that the radiosurgery procedures can involve the use of a head frame to immobilize the head, and the brain is an area of the body that doesn't move. And we've found over the past several years that being able to better manage the natural motion of different organs in the body has allowed us to perform stereotactic radiation treatments in these other sites. So areas like the lung or areas in the abdomen where there's a lot more respiratory motion. There have been a lot of new strategies for both imaging these sites during treatment as well as managing the motion of these sites during treatment.
I want to extend my thanks again to Dr. Feng and Dr. Hong. Thank you so much for such a lively discussion and wonderful presentation.